No, I agree with you, LaShawn. I think we need more data in the real world because it's kind of early.
LaShawn did a good job of summarizing at the end. Like it's while I'm all for ultrasound, I think everybody knows that this paper alone doesn't prove lung ultrasound in kids is ready to be the tool for diagnostic certainty of pediatric pneumonia. And figure 2, part A and B, that's the sensitivity and specificity with associated confidence intervals. And because the sample size is so small, there was not the power in any of these studies or as really an aggregate to say that the conclusions in the abstract of 95, 96% are adequate. The intervals range from sensitivities as low as 69% all the way to 100%. Same thing for specificity. One paper, the Self-LDN et al. Paper, has specificities from 15.8% to 100% for their confidence interval. And those, in both the sensitivity and specificity, the sensitivity has an I-squared of 65.5%, so a ton of heterogeneity. I-squared is 47.8% for specificity. So results are all over the board. The confidence interval is not narrow. You can't really say, it's kind of unfair in the abstract to say that the sensitivity and specificity is that great. It's not ready for prime time.
Yeah, I would. First of all, with regard to the third world setting, it's difficult to find places to hook your ultrasound up. We found that problem in Gambia. It's just finding an electrical source is a problem. So it's not necessarily something that's going to be a boon to the third world. The other thing I would point out is that we have been talking at length about some of the ultrasound studies for appendicitis in children. And Dr. Walters likes to quote an article that showed ridiculously high sensitivity and specificity, ridiculously high in the sense that it doesn't even approach the reality here at MCG. What was probably going on in that study that he quotes is that they had a very highly experienced ultrasonographer doing the study. And in that sense, that study is very center specific. It's not necessarily a generalizable result that they got. In our center, we have found many, 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 many false negatives. And in fact, there's some work that's being done, Kevin, looking at the ultrasound versus CT at our institution. So I think you need to look at the ultrasound studies with a grain of salt because you need to understand that it very much depends on the operator. Having said that, I would agree that this is a tool that we should be looking at. And I know that Matt and Rich and others have found that it is very helpful in diagnosing all kinds of things, including pneumonia. And I think that this probably will be something that will be getting used in the future. Somebody mentioned that this is just in its infancy. It is, but I think that it's in a stage that we should be watching very closely because I think we will be using ultrasound in a very broad fashion in the ED down the road. My last comment, I'm a little bit uneasy about the concept of folks using ultrasound for something like pneumonia in a broad fashion, in the same sense that I was and still am appalled by the arrival of the respiratory panel. That's a tool that has certain narrow uses. It's been abused, in my opinion. It's extremely expensive, and it's basically run up a lot of costs without a whole lot of benefit, in my opinion. I am a little bit uneasy that we've got in ultrasound a tool that there's a vested interest, in a sense, and this is not a slam against ultrasound in general, but just pointing out this is something that gives incentive to folks to be using a tool that they can then charge for and driving up costs. In most cases, pneumonia in children is a clinical diagnosis. Most folks outside of RED treat it as a clinical diagnosis. In many cases, they don't even get chest x-rays. You just treat it because it looks like pneumonia.
Jim, would you be worried, though, that some of those people that are clinically diagnosed, because I agree that if you have positive lung findings, for me, that kind of rules in pneumonia, because if I hear crackles, I'm in. But if I think that some people in the community, if you look at the antibiotic rates, are calling a lot of pneumonias that maybe their stethoscope's better than mine, but there's probably a lot of overdiagnosis, and some of that might be, it's kind of a hassle to get a chest x-ray from the pediatric clinic. And maybe they don't have an ultrasound machine because they're still kind of expensive and they haven't had the training. So could some of those clinical diagnoses be overdiagnoses?
Absolutely, a lot of those clinical diagnoses could be overdiagnoses, but I would also point out that many of the X-ray diagnoses are overdiagnoses. There's lots and lots and lots of people that come into the ED saying, I was put on these antibiotics 3 days ago, my kid was put on these antibiotics 3 days ago, they're no better. And I look at the X-ray, I don't see anything there. Whoever called it was calling just a little blush on the X-ray. Meanwhile, the kid had clinical symptoms that were not compatible with pneumonia. So I think you're getting overcalls both on X-ray and clinically.
Roy Spiegel just had a blog post on EM Nerd that addressed a more recent paper that wasn't included in this meta-analysis that talked about using ultrasound increased your use of antibiotics by about, I think it's like 16% or so. So you are using a very sensitive tool. Like ultrasound is definitely picking up some stuff that other things are missing, including physical exam and chest x-ray. And whether or not getting similar outcomes based on increased antibiotic usage is a very sticky situation. Honestly, we aren't ready to do randomized controlled trials of positive findings of kids with pneumonia and giving one group placebos. Like that's not really in the discussion, and IRBs aren't going to allow that. Most kids clear their pneumonias like that most of the time they do.
So I think in talking about the overcall for pneumonias that are probably happening out in the community, a lot of the pediatricians and primaries who are doing it are treating someone who says, I need antibiotics because I have a cough. They're not overhearing something. They're treating their patient satisfaction scores and making sure that person comes back to them and doesn't find a doctor who's going to cater to that. We can get away with saying, no, it's viral, go away, because we're the ER.
And that's a great point, that most clinicians are savvy now that if they put viral URI and they still write a Z-Pak in the age of electronic medical records, that looks really bad, and it still happens, unfortunately. And the more savvy ones are even realizing that putting down bronchitis and giving antibiotics, you're going down a slippery slope where so many cases of bronchitis are actually viral in etiology and don't need antibiotics and so forth. So then you end up with, they're just calling it pneumonia.
I think that this is very interesting, and I'm a very big proponent of ultrasound, but I also think you have to temper the enthusiasm with some of the indications with the fact that, anytime you have a new technology, there's a tendency to want to use it, and in some cases maybe use it or overutilize it. I mean, I would equate this somewhat to using ultrasound for things like fractures. I mean, you can do it, sure, but I'm not sure you necessarily should be doing it. It's unclear what the real benefit would be. I mean, my focus would be on trying to get people trained in the core studies where ultrasound has a clear benefit at the bedside, and we're not even really to that point yet. We haven't even come close to saturating even academic centers like ours with a full complement of faculty that can adequately do most of the major scans, much less in the community. So I think that's where the focus should be, although we shouldn't, not look for new frontiers, but I think that some areas are clearly beneficial with ultrasound, but I don't think this is one of them.
I would just say that listening to the discussions, I mean, it's really easy to look at an ultrasound and say that's a piece of radiology technology. It's been used by radiologists for a long period of time. So you think of it as an extension of radiology. Here's a radiologist, this is how I'm going to use it. Radiologists don't have a lot of clinical information. You guys write down cough, and then they look at an x-ray or they look at an ultrasound or whatever, and they come up with a diagnosis. Clinician use of ultrasound is very different in that you're the clinician, you've got a history, you got a physical, you've touched the patient, you look at the ultrasound, you see how things match up. They are inseparable. And this is what Rich and I always talk about is that you can't just look at ultrasound in isolation. And so looking at papers like this where you're looking at ultrasound in isolation, especially when the clinician can't know the results, makes it very difficult to know how good ultrasound is. It's very similar. I mean, Daryl kind of put a knife in my heart when he goes, it's like an extension of the physical exam, or a stethoscope. But I agree that you couldn't just take a stethoscope and walk up to somebody and listen to the lungs and go, you have X. You have to ask them questions and those kind of things. So it is very similar in that regard. You can't take one without the other. And so it's very easy, again, one more time, to look at ultrasound and say I'm going to use this in isolation. You can't use ultrasound in isolation, particularly for this. When you're talking about abstract things like lung ultrasound or even fractures, if you come up with that. If you're looking at more gallbladder stuff, AAA, those kind of things, those pure yes or no questions, it's a little different. But if you're talking about the abstract stuff, you got to have history and physical exam to go along with it.
So I think that Matt brings up a great point there that you need to match those up. And for me, if I don't think that it's likely that you have a pneumonia and I get a chest x-ray for some other reason, maybe you look sick or something like that, then I'm done. And I don't want an ultrasound to find that group so I increase my antibiotic use. But that kid that you think really looks sick and, your clinical history in particular, because honestly, if I hear it with my stethoscope, I just call it pneumonia and I'm done. But if I don't hear the pneumonia, but I'm really thinking it, that's when I'm using ultrasound now. Because, I want to make that diagnosis if it's there while avoiding overdiagnosis when possible.
So just really quickly, I was just direct a question to Lyon and Gordon. Y'all being the experienced sonographers in the room with an H&P and an ultrasound, how confident are y'all at picking up a pneumonia compared to just the radiologist doing it with just an x-ray, nothing else?
So in adults, see mostly adults, x-ray is much inferior to ultrasound. Ultrasound is very similar to CT for picking up pneumonias. Now going back to what Dr. Wilde said, it's very difficult sometimes to tell the difference between a viral and a bacterial. There are some literature out there, Tim Jang for one, that is a pediatric emergency medicine, and he has some criteria that help you decide between viral and bacterial, though a lot of that stuff was done during H1N1, so maybe it's a little different. I feel very confident picking up pneumonias with ultrasound. Whether they're bacterial, that's hard.
I'll tack on to what Matt said. I mean, a lot of it is about the clinical picture. If the child is well looking, I hear maybe some crackles on the base. Kid's not hypoxic. I may run a ultrasound over him to see if I see any B lines. If I see maybe some small B lines, maybe a small focused area of B lines, but no consolidation. Again, the kid's well looking. I'll give him strict return precautions personally. If I see a consolidated lung, I don't care. I don't need an x-ray. I'm treating that, and I'm not getting an x-ray. So they can get it upstairs if I admit them, or I will send them home, and I have sent them home. I've told them they have a pneumonia. So, again, a lot of that is a clinical metric. If they don't look well, obviously they're getting meted. If they do look well, I will send them home. So it really doesn't have anything to do, or it has little to do with the ultrasound. It's about the clinical picture.
There are times when we're getting x-rays because we aren't sure that, there may be a pneumonia there. But I would argue, at least in the pediatric world, most of the time when we're getting an x-ray, it's not to make the diagnosis. It's to assess the severity. In most cases, if the kid's tachypnic and febrile and has a low pulse ox, I've already made the diagnosis of pneumonia. What I'm looking for now is whether there's an effusion, whether it's socked in lung, does the kid need to go to the PICU because there's a complete whiteout. That's why I'm getting the chest x-ray. I think you kind of need to step back a little bit and think about why we're getting the x-ray in the first place. And I don't think I'm an isolated clinician in that sense. I think most of us on the peds side are making the call based on the history and the physical exam. And the x-ray is supplemental. In that sense, I think ultrasound would be quite helpful for the reason that Rich just outlined. You're looking at the severity. You're looking to see if there's an effusion there. And in that sense, I think ultrasound may very well be a very good tool.
Bayesian statistics and pretest probability. I mean, that's kind of the issue with the kids, is that your pretest probability for a lot of kids is that it's a viral pneumonia, more likely than not. In adults, the utility of ultrasound is probably a bit higher because you're suspecting that perhaps there's a higher prevalence and higher pretest probability for bacterial pneumonia in adults.